Hello, my name's John Walley. I'm Co-Research Director for COMDIS Health Service Delivery. COMDIS stands for Communicable Diseases, but in COMDIS Health Service Delivery we're dealing with both communicable, such as drug-resistant TB, and non-communicable diseases. So I'm going to talk to you about health service delivery and how we see that, as well as specifically about chronic disease, cardiovascular diseases, and our embedded research and development approach. So health service delivery and health systems, it's not always easy to see how the two relate, and I'll start with the WHO building blocks, which you're familiar with, which has the drugs, information system, finance, and human resources and leadership governance blocks. And I think the service delivery block should be on top of those, so that the health systems blocks are enabling the service delivery block. And the service delivery block enables delivery at high quality and coverage of intervention strategies. In our case, we generally are working our service delivery within the district health system and designing things that way. Now, that's not always the case. I mean, there are situations such as in insecure post-conflict or campaign situations, such as in Somalia, for example, and that you would do it vertically. But generally, we're designing our service delivery within the context of a district health system, and we're trying to make sure that we do so in a way that strengthens that district health system. So when we're designing for our TB work and now with non-communicable packages of care for those groups of diseases, we're working on the details for human resource or finance and so on within the general management systems, the general finance, human resource, etc. systems, and doing it in a way that will ensure the delivery of those group of disease interventions at the same time as strengthening those for the general district health system. So in that way, it enables quality delivery at large scale, and also ensures that you can replicate it and sustain it. So that's our district health way of working our service delivery. And so I'm going to talk about chronic cardiovascular and other non-communicable diseases. We've learned from our communicable disease work, TB, etc., to how to do public health programs which are systematic, enable wide coverage and delivery with high quality. And we're applying those same approaches to the non-communicable, with an emphasis on primary care and community treatment support and education. And so in the case of cardiovascular diseases, we've done a generic package of tools, guidelines for the clinician, guidelines for the person doing the lifestyle education, tobacco cessation, etc., together with modules that teach those guidelines, treatment cards, registers for performance management of the facility, etc., as exists for TB. We've developed all those things here based on the best available evidence, including WHO guidelines, and these are now in a form that you can use them for clinical care. And now our partners, COMDIS-HSD partners in China, Pakistan, Bangladesh, Swaziland, Nigeria, are all working on adapting these guidelines to their country context, their disease context, their health service delivery, etc., health systems context. And in the case of China, some very big important policies such as the new rural health insurance and the capitation-based public health package, and that pays for vaccinations, and it pays for health checks for older people, and we're working within those policies to help with these guides and packages of care service delivery to ensure that they're delivered with good quality and effectively influencing people's health. Indeed, our work and piloting has revised those tools, and we're now at the stage of starting a randomized controlled trial pretty large scale, 30 intervention sites and 30 control sites, and their catchment areas. And we are going to test what the cardiovascular event rates, deaths, myocardial infarctions, strokes, is in the intervention areas compared to the control sites. And that is possible in China because you've got this excellent internet-based reporting system for cardiovascular events. In other countries, we're doing it on mean hemoglobin A for diabetes control or hypertension control, etc., such as in Pakistan and Nigeria. So with those trials, we'll also, alongside them, do process evaluations, quality study, costing studies to understand what's going on and how the delivery is in detail, and from that help interpret the results of the trial, but also to revise the materials and make them suitable then for scale up by the ministry program. Now, we do all this in an embedded research and development approach, and that's one reason why we can do such large trials. We've got something like 22 projects within COMDIS, and the China cardiovascular one is just one out of those 22. We're able to do these large-scale trials and studies through this embedded approach, where we're working from start to finish with the Ministry of Health programs in these countries, and that partnership is such that they are paying for the intervention, the staff, the drugs, the tests, etc. In some countries there's also donor money, such as in Africa, involved, and we are providing the technical input, working with country partners on the development of the intervention, the service delivery, and on doing the evaluation alongside the early site implementation in these countries. So it's a partnership, which means that there's a lot of commitment generated by the program by working with them throughout. It's not doing a piece of research and then trying to sell it to the program. It's a partnership from start to finish, and as a result they're committed to scale it up, and generally our work is scaled up to provincial and commonly national level. And so in terms of research uptake, there's a lot of policy and practice change. So this is how we work, this is how we interpret service delivery, and have applied it from communicable diseases like TB and now drug-resistant TB and urban health and community interventions and cardiovascular diseases. And we are in the process of achieving research uptake, policy and practice change.